Okay, so we've talked about mental illness and theories as to what causes it. Well, how do you treat it? What do you do about it? Somebody's having behavior that would be considered abnormal. What are the different options? First of all, let's talk a little bit about the history. You go back, way back when, to the Middle Ages, and even a little more recently, people were thinking about psychological disorders as demonic possession. What would be the treatment for that? It would be a spiritual treatment. It would be things like exorcism, things like having a priest come over, things like that. That would be the treatment we went with. We went from that to, we had, after that it was asylums. Let's lock them up. People with mental illness, they just need to be put away. There really wasn't much treatment being done. And then we got to the source of thinking of it kind of as a medical model. We went to mental hospitals, which were big institutions, but that's where you had things like lobotomies and a big run of ECT, electroconvulsive therapies. You started to get this medical model where people were put in big-time mental hospitals. A little better than asylums, but you're still talking big hospitals and treatment was not the best. And then came the mid to late 1900s. So about the mid-1900s, we started developing more drug therapies. And people were given drugs. In particular, there was a change in that there were antipsychotic medicines that were developed. So people with things like schizophrenia could get medicine. So that led to what is known now as the big run of deinstitutionalization in the mid to late 1900s, where they were in mental hospitals, then they were given drugs and, quote, cured and released. Okay, here, take your meds. Not that simple. People were released, and then the problem is giving them follow-up care, giving them care to make sure that they take their meds, giving them care to make sure they're still getting therapy, they're getting ongoing treatment. Because a lot of times, mental health is not something that you can just cure, and it's done. It requires ongoing symptom relief, ongoing treatment. A lot of mental health is a chronic illness. It's like somebody who has diabetes. You can't just boom, cure it, you don't have diabetes anymore. You have to constantly be on top of it. That's what a lot of mental health issues are. Something that you have to constantly be on top of. Well, that was the potential problem with deinstitutionalization, because people got out of mental hospitals, but then they didn't have the follow-up care. Nowadays, the goal is kind of to have people have as much freedom as they can, to have a lot of community-based care, smaller facilities where people can get the help that they need. The problem is that it's still underfunded, and in some cases it's hard to find. So there's still some issues. It's not perfect. I think the goal, though, is to have more community-based care that is not necessarily you're admitted into a big hospital, but you go on an outpatient basis for treatment. That's the goal. Okay? That's the current status. Well, what are the different treatment options? There's two basically big different options. One is psychotherapy, which is counseling, talking to people. And there's different types. And then there's different medical treatments, talk drugs. So let's talk about the different talk therapies, the different psychotherapies that are available. One is psychodynamic or psychoanalysis. When you think psychodynamic, psychoanalysis, think who? Freud. He was the first guy who established this. What are some of the hallmarks? Well, psychoanalysis is this idea of you talk to somebody with the goal of uncovering those unconscious desires and motives and letting them go. Because letting them go is going to help solve the behavior. If you understand the behavior and you kind of acknowledge those unconscious motives is going to help cure, not cure necessarily, but it's going to help the behavior. How do you do that? Well, one is free association. That's where you come in and the therapist says, tell me what you're thinking about. Just tell me what comes to mind. It's a stream of thought. The goal being that stream of thought is going to uncover some of those unconscious motives. So that free association, just say what comes to mind. So tell me what you're thinking about. Another thing is dream analysis. Sometimes people from the psychoanalytic tradition will have the person tell them what they've been dreaming about. The theory being that sometimes those unconscious motives and desires will come out in dreams. And then the other thing is this idea of transference. Somebody from a psychoanalytic tradition is can be very attuned to what the person is saying about their therapist, because one of the ideas is that they're going to transfer those unconscious motives or desires to the therapist. They're going to be talking about the therapist like they would about somebody else that they have an unconscious motive or desire towards. So that's transference. Then you have kind of the opposite. You have psychoanalysis and you have this behavioral tradition. Behavioral therapies don't necessarily focus on the whys. They don't necessarily focus on, don't necessarily focus on why you're doing what you're doing, but they focus on changing the behavior, focus on what's observable. And they go back to the whole learning aspect of operating classical conditioning. One of the first ones is aversive conditioning. Aversive conditioning is if you've learned a behavior and you've learned a positive association, you want to, instead of a positive association, you want to learn a negative association. That's where, for instance, somebody will take, if somebody is an alcoholic, they may take medicine to make them sick when they drink alcohol. Because the idea is creating an aversion to that behavior. It's anything, aversion therapy, aversive conditioning is where you take a behavior that has previously gotten reinforcement, and instead create punishment so that the behavior is diminished. The next thing is systematic desensitization, and this is a big option in terms of behavioral therapies. This is used when you're talking about people dealing with phobias sometimes. What they'll do is you will create a list of things. For instance, if you have a phobia of spiders, you create a list of things in terms of least terrifying to most terrifying. Least terrifying may be looking at a picture of a spider, all the way up to letting a tarantula crawl all over you. And what the therapist will do is teach you techniques to relax yourself and then gradually take that person through those steps, gradually take them from the least terrifying to the most. In other words, start with something that just makes them a little bit anxious and then go up until they're able to handle the one that creates the most fear. Now, you can use this with things like OCD too. You can use this in terms of if somebody has a compulsion to hand wash. You can say, okay, going an hour without washing my hands makes me a little bit queasy. Let's see if we can handle that. And then you step it up. That's the whole systematic desensitization. You start little and you step it up. Another option in terms of behavioral therapies is token economies. You see token economies a lot of times in schools for kids with behavioral issues. And sometimes you see it in adult treatment centers too, but it's basically you get rewarded for good behavior. If your behavior is what you want it to be, you get a little token or something that you can exchange for something you like. Typically it's at a school store or something like that. But you get some kind of token or slip of paper or something, and you can exchange that for something that you like. It's basically being reinforced for good behavior. And if you don't behave well, you don't get the tokens. That's the token economy. and it increases behavior that is wanted because people want those tokens. So that's some different behavioral therapies. Then you get into cognitive and cognitive behavior. Cognitive therapies think not necessarily about the behavior itself, but go into what's the thoughts behind the behavior. In other words, somebody who's depressed, the behavior may be not getting out of bed. Well, what's the thoughts behind it? It's the person thinking, oh my gosh, I'm a failure. Okay? So how do you change the thought, I'm a failure, I never succeeded anything? You go through and you say, well, what about that time? You succeeded when you did this, and giving them an example, you challenging that. Those are forms of cognitive therapy, where you're going to change the thoughts. You're changing those negative thoughts. Okay, and it's really focused on that. It's focused on talk me through what you're thinking. Talk me through what you're processing. Cognitive behavioral ties in those thoughts with the behavior more. It's kind of that in between behavioral and cognitive therapy. Ties in with the behavior more. Pure cognitive is just talking about those thoughts. Okay. Humanistic is a type of therapy that goes into the emotions more. It's not as strict, okay, let's provide you evidence, as cognitive is. It's more, how are you feeling? What things can you do to be successful? Well, what was going on then? What time in your life have you felt like you've been on top of things? That's kind of the humanistic focuses on people's strengths and focuses on the therapist is giving that person a sense of acceptance and letting that person feel like they're valued and listened to. That's the whole humanistic viewpoint. Okay? So, when you're looking at all these talk therapies, what makes them good, what makes them bad? Well, some of the things that have been linked to success, one is motivation. If a person wants to get better, if a person wants to go to therapy, it's more likely going to work. It's that expectation. If you expect it to work, it's more likely to work. That trust in the therapist. If a person has a bond and or trust with a therapist, it's more likely to work. Hope. If a person, again, it's tied back to those expectations. If a person thinks that it's going to work, if they think it might work, if they have hope that this therapy might work, it is more likely to work. Therapy is more likely to work if it is consistent. Therapy is more likely to work if the therapist has a bond, again, with the person. There's a lot of, if the therapist, basically it's, what is the disorder? Does the therapy fit the disorder? Does the therapy fit the lifestyle, psychology? Does it fit the person, the client? And is there that relationship there? There's a lot of things going on. Psychotherapy can be successful. It can also be a waste of time. It depends on a lot of factors. And a lot of times, psychotherapy is used in conjunction with medical treatments. And that's the next big thing. Talking medical treatments, the big thing is medication, drugs. Talk about, for instance, mood disorders. Antidepressants. One of the common antidepressants is what's called SSRIs, specific serotonin reuptake inhibitor. And that basically is a drug that helps keep serotonin, the neurotransmitter serotonin in your system. We talked about earlier, when you talked about the action potential and how neurotransmitters go from one neuron to another. What happens is one neuron spits out those chemicals. Okay? and they're taken in by the other neuron. Now, what the reuptake inhibitor does is it prevents that first neuron from sucking back in that serotonin. So the serotonin stays in that synapse, in that gap between the neurons longer, and it's more likely to be taken in. So it creates more of that, it makes more of that neurotransmitter in the system. Antidepressants work on serotonin, some of them work on norepinephrine. Mood stabilizers. Traditionally, bipolar disorder was treated with a different drug. Traditionally, it was a form of lithium. Now there are some newer drugs that are meant for bipolar. You see, there's a lot of commercials nowadays. Bipolar depression. There's some new drugs out there. As I said, traditionally it was lithium. Now there are some different ones. Then we have antipsychotics. Antipsychotics are drugs that are taken primarily for people with forms of schizophrenia, and it helps with the positive symptoms of schizophrenia. Some of them work on dopamine receptors, but it helps reduce the hallucinations, delusions. It reduces those positive symptoms, hopefully. Do all of them work all of the time? No. And then we have anti-anxiety drugs. Okay, Xanax, stuff like that. And there's newer versions. Again, it's drugs that work on neurotransmitters, and some anti-anxiety drugs just basically calm you down. So then there's anti-anxiety drugs. Typically, what happens is, for instance, if somebody is diagnosed with schizophrenia, they will be given some antipsychotic medication plus some psychotherapy. Or somebody is diagnosed with depression. They may be given antidepressants plus have an appointment with a therapist. So it's a lot of this treatment being not just one or the other, but a combo. Because you want to treat the chemical imbalances, but you also want to treat the environmental stuff and the thought processes that are going on. You want to treat some of the stuff that is built up. There are two other treatments that are in the medical realm. One is ECT, or electroconvulsive therapy, which is basically shocking the brain. You're shocking the brain, and it basically causes somebody to have convulsions. It was something that was used a while ago pretty commonly, and it was, as I said, it was used decently commonly, and the problem was it would cause some serious side effects, because people didn't, it was just kind of, you put these things on people's brain and you zapped them with current, and then they would have a convulsion, and there would be physical side effects to that. Nowadays, it's used, but it's used a lot more sparingly. It's used as a last resort, and it's used in conjunction with muscle relaxers and some more things to make it safer. So nowadays, it is still used, but it's not used as commonly, and it's used in a safer mode. In other words, we know more about it. So it's not that it's never used, it's just not used as often, and it basically is a last resort, and there have been some changes to it to make it safer. The last thing is surgery. Yes, people have gone through surgery to solve psychological disorders. Think about this. If you have an issue with a structure in your brain, there are people that have gone through brain surgery and had parts of their brain messed with, for lack of a better word, zapped. And again, this is something that is done, but it's something that's done as a last resort. The other stuff is tried first, okay, because this is more of a permanent thing. So there's ECT and surgery. Then we want to talk about treatment modalities, individual versus group therapy. Individual therapy can be good if somebody wants to get insight into what their issues are. Things like psychotherapy are a lot of times done individually because it's kind of their issue and they want to get insight into why their behavior is the way they are. Okay? Group therapy is often used for things like, we're going to talk about addiction. It's used for that. It's used for disorders that can affect the person's lifestyle and disorders that can be seen in conjunction with some of those family dynamics and any disorder that has a social component. Some disadvantages of group therapy are that a person may be less likely to be free with what they're talking about because there's people around them. So if they're in the presence of others, they may not speak out as much. However, group therapy can be cheaper because you're treating multiple people at the same time. In group therapy, the therapist can see how the person is interacting with others and get some really valuable insights by watching how that person interacts with others. So that's a big advantage. Some types of group therapy, couples therapy and family therapy, can be very beneficial because you're working on fixing those dynamics. And especially like when you're treating addiction. Those group therapies work better because you're treating some of those dynamics which can cause some addictive episodes. And another advantage of group therapy is a person can see that they're not alone. That there's other people that are struggling with the same things they are. That can be important when you're treating addiction too. Another thing, comorbid disorders. This is another thing to think about when you're looking at therapies. Disorders aren't nice and simple. A person doesn't just have this or just have that. A number of people have multiple disorders and multiple things associated with those disorders. And you have to, when you're talking about medications, when you're talking about psychotherapy, you have to think about what may be good for one disorder may be bad for another. If you're working with family dynamics, that may have an effect on other social dynamics. You got to think about what I would call the domino effects. And that's where comorbid disorders come in. A lot of times it's not that simple. People have multiple things going on at the same time. Then we have cultural issues and barriers for treatment. And that's kind of the last thing to think about. Cultural issues. When you're going into therapy, culture is important because remember when we talked about the stigma of mental illness? Different cultures have different stigmas and different thoughts about what causes mental illness. You have if you come from a cultural background where there is a spiritual component to mental illness, it's okay to acknowledge that as a therapist. And they would want a therapist who would acknowledge that. Cultural components mean a therapist looking at the resources that person has. And there's where it comes in. Sometimes it is better for a therapist to be of a similar cultural background as the person they're giving therapy to. Sometimes. Now, I say that, and just because you're from a certain cultural background doesn't mean that automatically it's not going to work with a therapist from a different background. It very well could work. And just because you look one way doesn't mean you grew up in that culture. You could have somebody who is Asian American, but is totally American. In other words, they're third generation. They have very little. They have very little knowledge of that cultural background. So I would say this whole cultural issues, take into account the whole person. Don't just assume. And I think that's what therapists need to do. They don't just assume. They look at, where did this person grow up? I mean, what is their history? Get their story, get their narrative, and then find out what is the best therapist that would fit with that narrative. Okay. Barriers to treatment. What causes people not to get treatment? The biggest is financial. I think there's two things. There's three things going on. One, financial. Two, stigma. They don't want to admit that they have a disorder, and they don't want to go to treatment. And three, logistics. Treatment takes time. And it's difficult for somebody to take that much time to come to therapy. So you have time, money, and stigma. And just logistics other than time, like transportation to get there. What will be interesting is in the coming years, what's going to happen in terms of funding of mental health treatment, in terms of is it going to get more expensive, less expensive, what is the health insurance? There's this whole health insurance debate. Is it going to mean more people have insurance that's going to cover it or not? Are people going to be able to pay for it? Right now, what you're seeing is a lot of people have very high deductible insurance, which may cause some people not to seek treatment because they can't afford to pay it out of pocket. And high deductible means you pay a lot of it out of pocket. But it could also mean that people are thinking twice and being creative and using other methods too. So there's a lot of things going on. I would say, again, the biggest barrier, financial, logistical, stigma, and I challenge people to think of other possible barriers to treatment. So that's treatment. Again, it's not simple, but people who have mental illness need help. And the question is, what are the resources? What is the best way to give them that help?